Hello and welcome. I'm Jeunesse Castonguay, VP at Clarius. We're excited to see you all here for today's live webinar, Ultrasound-Guided Techniques to Rapidly Dissolve Fillers Part 1, Misplaced Facial Fillers. Today we'll be joined by renowned medical aesthetic expert and educator, Dr. MJ Rowland-Warmann, as she teaches simple techniques for identifying misplaced facial fillers and treating them efficiently under ultrasound guidance. Dr. MJ considers ultrasound the most groundbreaking development in aesthetic medicine since the invention of filler. You'll learn the basics of dissolving misplaced facial fillers under ultrasound guidance, keeping it achievable and attainable for everyone from beginners to seasoned aesthetic practitioners. Before we get started, I'd like to welcome all of you. You're among over 2,400 medical estheticians, plastic surgeons, nurses, physician assistants, dentists, and other clinicians who registered for today's popular event. Good morning, good day, good evening, depending on which corner of the world you're joining us from. A quick housekeeping note, please do feel free to use the questions box at any time during today's webinar, as there will be a live Q&A session following the presentation and our live scanning. It's now my pleasure to introduce you to Shelley Gunther, your host for today's event. Shelley is an experienced sonographer with over 25 years of experience as a clinical ultrasound expert. As clinical manager at Clarius, Shelley is dedicated to providing the highest quality educational content for clinicians looking to add wireless ultrasound to their practice. She helps us deliver practical webinars like today's event and video tutorials for our Clarius Classroom, which now features over 200 on-demand videos. Join me now in welcoming your host. Hi, Shelley.
Hi, Jeunesse. Thanks for the kind introduction and welcome, everybody. I'm really excited to be welcoming Dr. MJ back for another content-rich and informative webinar about the most common complications she sees in her practice. If you're fortunate enough to have ultrasound in your practice, you may already be familiar with existing imaging of existing fillers. And if you're new to ultrasound, you'll see that it's actually not that difficult to locate and identify fillers, and treating them is very achievable for anyone who may encounter a misplaced filler. Thanks to passionate leaders like Dr. MJ, the use of ultrasound continues to increase among practitioners. It's absolutely all about being able to visualize under the skin to identify facial anatomy, and in this case, dealing with fillers that you find where they shouldn't be. When you encounter somebody in this situation in your practice, wouldn't it be great to be able to treat your patient instead of having to refer them somewhere else? We're going to see some great examples, tips, and tricks in this webinar that we hope will increase your confidence so that you can begin treating problem fillers. Now, to set the stage for this presentation, I did a bit of review of recent literature, and there's a lot of great articles out there. The first one is from the Journal of Cosmetic Dermatology, and it reminds us that even though HA filler injections are relatively safe, complications can occur. And ultrasound is an invaluable tool, not only to improve the safety of HA filler injections, but in identifying complications that may occur and to guide treatment. In the next paper, it's a fairly recent article, and it describes how we're able to successfully characterize dermal fillers with ultrasound. Different fillers have different distinct ultrasound characteristics, and the identification of these will allow practitioners like yourselves to choose the best therapeutic approach in patients who underwent previous aesthetic treatments. And this next article looks at a few cases of soft tissue filler that ended up or migrated to locations other than where they were intended to be. It's a review of literature to determine the cause or causes. The authors state that soft tissue fillers are recognized as foreign bodies in our systems, and therefore they have the potential for a myriad of complications, both immediately after injection and potentially months or years later. So to be aware that if a patient presents with a mass, a nodule or swelling in the face, and a history of filler injections, this may be what they're dealing with. Now, the good news in here is that 2 of the 3 patients in this study had successful treatments of their fillers with hyaluronidase. And finally, this in-depth consensus from the EFSUMB steering committee for the dermatologic use of ultrasound has developed a series of statements regarding ultrasound of the skin, which includes recommendations for technical requirements of ultrasound equipment used for aesthetic procedures. Position statement 2 actually says that there was very strong agreement that the minimum transducer frequency for dermatologic ultrasound should be at least 15 megahertz. Higher transducer frequencies may provide further information that may be relevant, and there was broad agreement on this. Position statement 3, color Doppler, power Doppler, and pulse spectral Doppler, in the case of vascular anomalies, are recommended to establish inflammatory state of skin and appendages and the presence of neovascularization. Strong agreement on that one. And on the final slide here, there's a section dedicated specifically to aesthetic dermatologic ultrasound, which recommends, due to the dramatic increase in aesthetic procedures by operators that have varying levels of training, ultrasound is a valuable tool for evaluating facial anatomy before and after aesthetic procedures, and in the detection and identification of cosmetic fillers and implants and treatment guidance when it's indicated. The Clarius L20, which Dr. MJ will be using to show us how she treats misplaced fillers, is the only wireless scanner that satisfies these technical recommendations and has very specialized presets for aesthetic and dermatology applications, as I'll show you later. Now, before we get on with Dr. MJ's presentation, we'd like to throw out some questions regarding what you see as the benefits ultrasound can bring to facial aesthetics. And this will help us better understand everyone's level of experience and specific needs. Are you wanting a better understanding of facial anatomy, or perhaps wanting to be more comfortable with facial vasculature before you inject? If you're treating, are you treating complications? Do you want to treat complications? Or are you simply looking for increased referrals to your practice? So let's give this about 5 more seconds before we close out the poll. 3, 2, 1. So it looks like a lot of you are wanting to locate vascular structures, just a better overall understanding of anatomy. So I think this will really, really help out. So without further delay, I'd like to hand things over to Dr. MJ Rowland-Warmann, founder and lead clinician at SmileWorks in Liverpool. Dr. MJ shifted from general dentistry to complete her master's in orthodontics and aesthetic medicine. And today she practices non-surgical aesthetics with a special interest in the management of dermal filler complications using ultrasound. Dr. MJ is an advocate for safer aesthetic procedures and has been widely published in industry and national media to help raise industry standards, which is fantastic. So take it away, Dr. MJ.
Thank you so much. Okay, hi everyone, and thank you for joining me tonight. There's a big crowd from all the corners of the globe. And thank you to Clarius for having me back for another webinar and the first in a series of complication management sessions. As Janez and Shelley have already introduced me, I'll keep it short. I'm a dentist. I'm based in the UK, where people love aesthetic treatments. Our industry is unregulated, so anyone, and I mean anyone, can legally inject. And that means I see a whole host of complications ranging from mild to really severe, from a few lumps and bumps to visual disturbances. And that has created a need for complication clinics on a regular basis within my practice, where I take referrals for problems that people have with filler. I've been using the Clarius L20 in my practice for around 2 years now, and I'm not kidding when I say it may be the best money I've ever spent. But let's not waste time singing its praises. I'm just going to go ahead and show you how great it is. Those of you who joined me for my last webinar a few months back will know that we can use ultrasound in aesthetic practice for a whole host of different indications. Using it in filler treatment is a godsend, whether that be before treatment to vascular map, during treatment to place filler using ultrasound guidance, or after treatment to confirm placement. It is key to predictable outcomes. We can check up on our filler over time, decide what's hidden in our patients' faces if we come across historic filler, and we can learn a huge amount of anatomy using it in our daily practice. But one major use is in dermal filler complications. Diagnosing and managing complications has arguably taken a giant leap forward since ultrasound. Being able to see beneath the surface of the skin to identify problems from filler is revolutionary. Gone are the days when we're left guessing what the problem is or even where the problem is. Now, this simple 2-minute diagnostic can help us resolve problems swiftly and effectively. Patients endure fewer interventions, less delays in diagnosing the problem, and the complication can often be found and fixed in the same session. And that's pretty wonderful. So complication management with the L20 is what I'm going to be talking to you about today. And specifically, we're going to be talking misplaced filler. So what is misplaced filler? Well, simply filler where it simply shouldn't be. This paper from way back in 2013 split complications into immediate and delayed. Misplacement of filler happens at the time of treatment, so it's immediate. It's in the incorrect plane or place and or adjacent to a structure which it might interfere with. Over time, errors in placement can also cause product spread or migration, as some people call it, due to tissue movement. So it also has delayed consequences. Now, the issue with a lot of misplaced filler is that it's just being left. Practitioners don't see it as serious enough to warrant intervention, and patients often don't experience problems severe enough to seek assistance. They're often told the symptoms will pass, and they feel like they're being overly sensitive or whingy if they counter this. But actually, it's the most common complication there is in aesthetics. It's the one that causes a huge amount of anguish for patients being left disfigured, sometimes for years. It causes the most amount of negative press for our industry. All these ugly results out there are simply bad for business. So you shouldn't just stand by and let these patients suffer. So I've chosen 2 misplaced filler cases today simply because this complication is ubiquitous. You will see it daily. And with your Clarius, you have the ability to bring about a swift and effective resolution. I know there are bigger and scarier complications out there, the occlusions or infections, but I wanted to give you something in this webinar that you can tackle very soon after starting out with ultrasound, identifying and eliminating the most common problem. That way, you can build your skills and work towards the more challenging problems that will undoubtedly come your way. So this is our first case for today. You might think she doesn't look too bad, but if you look closely, you can see the puffiness under her eyes. She presented with bilateral infraorbital swellings, which have been there since she had tear trough filler 18 months ago. They're not painful, they don't fluctuate, but they're unaesthetic. She was told by her injector that the filler had gone after all this time. But as we know from recent studies, like the 2021 by Mobin Master, filler sticks around for years, if not decades. So this is a classic case of an immediate complication not being handled and turning up delayed. Let's take a look at this case in a little bit more detail. Before we talk about diagnosis and management of this problem, we need to familiarize ourselves with the treatment area and understand what's normal and what's not. And to do that, we're going to use our Clarius. So let's take a look at the layers that we expect to see. This is the area of the lateral orbit, and we can see the skin, the subcutaneous fat is here is very thin, the orbicularis oculi muscle is underneath, and then there's the soup, and finally the bone. And as we move along to the medial aspect of the tear trough, there's just 3 layers: skin, orbicularis, and bone. The tissue here is much thinner. There's also a few vessels here that we need to be aware of in the area of the tear trough. The infraorbital foramen is around 10 millimeters inferior to the orbital rim, medial to the midpupillary line, and the infraorbital artery, vein, and nerve exit here. There's also the angular vein. This is 4 millimeters inferior to the orbital rim within the orbicularis oculi. At the midpupillary line, it's about 4 millimeters away from the periosteum, but can be as close as 1.5 millimeters to the bone in the medial tear trough. So the safe space for tear trough filler gets less and less lateral to medial. And there's very little room, so there's a risk of injury to the angular vein. The angular artery is a little bit more medial to the vein, so it's a bit more protected. And that's the findings from this paper from 2022. Now let's talk tear trough boundaries. The souff is bounded inferiorly by the zygomatico-cutaneous ligament, superiorly by the orbicularis retaining ligament. Deep is the bone and superficial is the orbicularis oculi muscle. This is where our filler should go in tear trough augmentation. Placement of filler superficial, so over the muscle, will result in edema. And if the product is placed through the orbicularis retaining ligament, the patient will end up with significant bags or even compromise to the inferior palpebral arteries in the eyelids, to medial and urine to the angular vessels. Filler treatment to the tear trough is tight and it's technically demanding. And that is part of the reason why tear trough problems are in the top 3 types of complications I see. In addition to placing it right, the right product needs to be chosen, one that isn't hygroscopic and draws in lots of water. Then we've got to select the patient correctly. A trough can be treated. A bag is much more difficult due to pre-existing fat pad herniation and tendency for edema. So it can be fraught with difficulty. This systematic review by Trin from 2022 showed that the most common delayed complications in the tear trough were swelling at 42.3%, nodules and lumps at 25%, and migration also featured at 7.7%. And it's overwhelmingly HA filler causing these issues. So if our patient is presenting with edema, even before scanning, we can have a good guess as to what we might see with ultrasound. We might find too much filler for the small space under the orbicularis, placement of filler behind the orbital septum, wrong case selection, such as patients with bags rather than troughs. We might have superficial placement of filler, wrong filler type, or filler might be irritating vessels, causing hypervascularity and edema. And this is something I'll discuss in just a moment. Now, let's take a look at our patient with the complication. We expect to see some rogue filler somewhere. So here I'm scanning the right infraorbital area with the center of the probe at about the mid-pupillary line. And we can see hyperechoic skin, isoechoic subcutaneous fat, hypoechoic muscle, isoechoic souff, and hyperechoic bone. And as I move the probe, an anechoic round deposit comes into view. Anechoic means it's dark on ultrasound because it doesn't reflect sound waves. That means it's either fluid filled like a vessel or it's a deposit of HA filler. And we can go ahead and check whether it's a vessel by turning on our color box and moving it around. Vessel come up as colored flashes. So you can see the black deposit here remains dark. So this tells me it's HA filler and it appears to be under the orbicularis. The flashing vessel at the bottom is the infraorbital artery coming out of the infraorbital foramen. That's the hyperechoic structure underneath that can be seen at the middle lower part of the screen. Interestingly, there's lots of flashes of vessels in this area around where the filler has been placed. And what often happens when filler is in close proximity to vessels is a phenomenon called hypervascularity. Filler is noxious, it's irritant to vessels. It causes them to proliferate, and what we see on ultrasound is lots of vessels in and around an area of filler. And this has been described by Schelke and others in their 2019 paper here. They showed a case of hypervascularity in the lip, but it is seen in many areas of the face and especially in the tear trough next to filler. Where filler is placed next to vessels, there will be inevitably a vascular response. And this response causes the symptoms of edema like in our patient. So filler next to vessels causes hypervascularity and edema. So what we see clinically is swelling, even if the filler appears to be in the right plane underneath the muscle. And this might be further exacerbated by the type of filler that's been used. Filler which is too hygroscopic can cause additional pressure and swelling, compounding this problem.
Dr. MJ, is the hypervascularity just seen immediately after injection, or is this something that you see months down the road?
This complication is 18 months old, and hypervascularity develops over time. If a vessel is being injured, the natural response, or being irritated, the natural response is to try and recruit its friends to the area to give it more blood supply and to give it more help.
Thank you.
So once the filler has been identified, I can go ahead and dissolve it. And I use the so-called in-plane technique, where my needle is in line with the probe and I can see the needle advancing on the screen to get to the filler. This is the easiest way of visualizing the needle and allows you to see its path and correct it with any minor movements. Once I'm at the filler, I go ahead and I place the hyaluronidase. And I'm actually going to go ahead and treat this deposit again with another dose. The filler treated just now, you can see, has taken on this cotton wool-like appearance. And this is very typical of filler after hyaluronidase, and it's due to the change in rheology affecting sound wave reflection. And to get rid of this filler, it's taken 2 tiny doses, no more than between 30 and 45 units per deposit. I work with a 5 ml dilution on 1500 units for this. So 0.1 ml is 30 units. And I find that this is the ideal concentration for aesthetic correction.
And are you finding that you're having to inject less hyaluronidase by using ultrasound?
Much less. Previously, when I wasn't using guided treatments, I would use probably the whole vial of 1500 units to flood the area. And it was just a sort of a shotgun approach. Whereas now, you know, it's like using a rifle. You're pinpoint accurate to the exact deposits of hyaluronic acid filler that you can see in real time and get rid of them. And the patient requires a much lower dose, and it is much swifter and it's much more effective.
Great.
So here's the treatment area immediately after the intervention with the hyaluronidase. We can see the blood vessels are quite agitated, and that's completely normal considering we've just been injecting near them. And if we go ahead and turn off the Doppler, we can see this cotton wool-like appearance again. This tells me my job here is done. The filler is on its way out, and I can send my patient home and review her in a couple of weeks.
And in a couple of weeks, would you still see that cotton wool appearance?
I'm going to share something with you in a second. But
Great.
No, that cotton wool appearance disappears probably about 20 minutes, half an hour afterwards. More on that later. So this is our second patient. She too is a delayed complication. She had forehead filler by an unlicensed practitioner who had injected her over the central part of the forehead. This picture was taken on the day of treatment, and she doesn't look like she's having a good time. Immediately after treatment, she experienced severe headaches, swelling, redness, and significant pain. So much so, she was out of work, incapacitated for some time. She didn't have any skin changes, so her practitioner didn't take her seriously. She eventually convinced her initial practitioner to see her, who attempted dissolution just the once, and then told her that's all that could be done for her because she didn't see a problem. This is her 8 weeks after her filler treatment on the day she presented to me. You can see that there's an area of swelling at the glabella. The lumpy swelling also extends into the forehead, to the hairline, to the right of the center. And at this stage, she was experiencing persistent headaches, diffuse swelling, and tenderness to touch the area. She'd had the complication for 2 months, and the psychological impact was obvious. She was frustrated, she was tearful, and she was frightened. And this is how many patients present with these complications. They're at the end of their tether, and they need delicate management. So being able to use ultrasound to tell them exactly what's going on is crucial to rebuild them emotionally and their trust in us aesthetic professionals. Now, many injectors don't treat the forehead with filler out of fear of the risks. In their 2019 update on avoiding and treating blindness from fillers, Belesny and colleagues found that whilst the nose was #1 site for vision loss from filler at a staggering 56.3%, the glabella at 27.1%, and the forehead at 18.8% were the second and third most risky areas for treatment. The supraorbital and supratrochlear artery are terminal branches of the ophthalmic. Introduction of filler to either, or even the superficial temporal artery, which anastomoses with them, can lead to filler reaching the eye and resulting in vision loss. According to a study by Agorgianitis in 2020, the average depth of the main forehead arteries is 1.5 millimeters with a diameter of 1 millimeter. It's expected that the supratrochlear artery courses 1 to 2 centimeters lateral to the midline and the supraorbital 2 to 4 centimeters. However, their course is highly variable and may have a plethora of branching patterns. So the only way you can predictably reduce risk when treating these areas with filler is to use ultrasound to identify the vessels. So when scanning the forehead, we expect to see most of the layers, including hyperechoic skin, isoechoic subcutaneous fat, hypoechoic frontalis, which is an indistinct band in the middle layer. The frontalis isn't easily identifiable as some other facial muscles. Then there's the hyperechoic subfrontalis fascia, a layer of loose areolar tissue, and hyperechoic periosteum and bone. Now, you might have been a little confused as to what's going on beneath the periosteum in the forehead. The periosteum is the deepest surface and sound waves don't pass through, so there's nothing beneath this layer. However, on your image there, you might get some extra lines beneath the solid white line of the periosteum, which can be confusing. This is a mirror artifact. This happens when the transmitted sound waves bounce off a highly reflective interface, a so-called acoustic mirror. In this case, it's the frontal bone. They return to the transducer and result in a signal and an image that can be really similar in shape to the structure they've been bounced off. In the forehead, the mirror artifact is often weaker and can be seen as these lines beneath the level of the bone. So let's do some more scanning, first in B mode. I've marked out in red pen on the skin the swollen and tender area to reference my scanning. Immediately, we can see round anechoic deposits that we suspect to be filler. Could be a vessel, they come up anechoic too, but it's a bit big for that. Moving a bit more cranially in the forehead, we can see the extent of the filler, and there is a lot. And further up still, there are more deposits at varying depths, and they are sizable. They're spread over much of the central part of the forehead.
If you had to hazard a guess, was that multiple injections, do you think, or is that just filler that's migrating?
You can see on the initial, picture that she took, there were injection points and puncture marks all over her forehead. And looking at this scale, some of these measure up to 5 millimeters. Now, let's switch to Doppler, and we can reconcile these findings with the vascular anatomy. And there's no colored flashes here, which means all of this is filler in the area of the glabella. So here's where it gets interesting. We're in the glabella at the supratrochlear. Agorgianitis described the supratrochlear as passing superficial to the corrugator, deep to the orbicularis and frontalis muscles with an extremely variable course with many branches. Advancing cranially, we see the supratrochlear come a little closer to the skin. And again, we've got a large filler deposit very close to a vessel. This is the area she described as painful. There's a big old filler deposit right next to a branch of the supratrochlear artery. As described by Schelke in the 2019 study I shared earlier, filler can irritate vessels. This can result in edema and pain because in the forehead, there's no room to expand. And a further worrying consequence might actually have been activation of choke anastomoses, which can lead to ischemia of the forehead. This can be due to irritation by filler and cause serious perfusion problems. So seeing filler this close to the vessel is really worrying. And now that I've identified the filler, I can go ahead and get rid of it. Key to this is getting a good position so you can visualize the needle. The forehead is only around 4 millimeters thick, so you've not got much margin for error before you're onto bone. My positioning here is in plane, so the longitudinal axis of the Clarius footplate is in line with the needle. And you can see my needle coming in here on the left of the screen towards the central filler deposit. And I deposit only a small amount of hyaluronidase as it is precisely targeted. Again, no more than 0.1 mil. This case is more tricky as there's multiple sites of filler which could be causing the problem and the symptoms. And the pulsating vessel that you'll see just now is likely to be the supraorbital. Placing hyaluronidase here can cause vessel injury, and she did end up with bruising. We must make patients aware they may be bruised after dissolving. And then moving more inferiorly towards the brow, you can see a very large vessel that's extremely close to the filler, whether the supraorbital or supratrochlear both have direct connections with the ophthalmic artery. So we can see here that this filler placement was very much a near hit. And whilst I go ahead and dissolve some more, I want to share with you 4 tips for guided dissolving. Angle your color box when you scan. An angled color box is much more likely to pick up vascular flow, so make sure you set yourself up correctly. Make sure you've got plenty of gel, so this acts as a cushion to prevent tissue compression. Especially in delicate areas like the face, applying pressure will skew your accuracy, so the more gel you have, the less you compress. I use ultrasound gel beneath a sterile probe cover on which I can then apply sterile ultrasound gel. You must make sure your procedure is clean, so you should be covering your Clarius with an appropriate cover for all guided procedures to prevent contamination. And finally, stabilize yourself. You can see here, I've got my hand rested firmly on the patient's head, and that's really important for stability. Don't be afraid of using parts of your patient's face as a rest. It will improve your precision immeasurably rather than attempting to hover awkwardly over your patient's face. And this scan was 1 hour after hyaluronidase treatment. And the reason I waited an hour for this patient is because she traveled over 5 hours to get to me in the first place, and I wanted to make sure the filler was gone. You can see that all of the black deposits have now disappeared. After around an hour, this is what we expect. And that cotton wool appearance we saw in the tear trough in the other case has also gone. And the filler is pretty well broken up completely.
That's amazing.
Yeah, isn't it? So here we can once again see the normal layered anatomy with skin, subcutaneous fat, frontalis, loose areolar tissue, and the bone. So I fixed her. Her complication is resolved. So what impact do you think this will have had on the patient? This procedure for the patient is seriously impressive. When you are properly trained and you can use your Clarius with ease, this kind of thing is revolutionary. She will go home happy, and I guarantee you she'll be a patient for life. What's more, she will refer all of her friends. So some of you may be handling complications already with your Clarius. For many of you, complications might be a new thing, or ultrasound might be new. So how do you go from simple scanning to managing complications? The best way is to incorporate ultrasound into your daily practice. Make sure you're using your Clarius every day for the simple stuff, recognizing anatomy and vascular mapping. Complications can be terrifying. When patients are upset, injured, or litigious, you could very easily get yourself into trouble if you aren't rehearsed with your skills. You might end up being the last in a long line of practitioners getting sued if it doesn't turn out well. So build your skills gradually. Rome wasn't built in a day, but it was built. If you're starting with complications, choose the everyday ones. Simple, guided hyaluronidase in patients who aren't too concerned or where misplaced filler is maybe an incidental finding. Like lips and easily identifiable filler in cheeks is great. This way, you can eliminate unpredictability in high-risk procedures by doing low-risk treatments with ease. Always ask for help if you're not sure. Complications can be very stressful for both the patient and for you. A second set of eyes on a case is often a very good thing, especially when you are learning. A little help in interpreting ultrasound scans can go a long way to solving a complication. And I can show you how to get there. Right, here comes the exciting part. As you know, at the Hub, we create world-class learning experiences so you can be better practitioners and grow your practice. After almost a year of hard work, instructional design, video editing, research, and all of that lovely stuff, we finally launched an online ultrasound course, which we are so proud of, and I want you all to sign up for, obviously. You can see some of the topics here. There's quite a lot of content, and the course will guarantee you the best start in ultrasound. If you have a Clarius, you can even scan along with the videos and demonstrations. You can study at home, and once you've completed the online accreditation, you can come to the Hub and learn with me at our state-of-the-art ultrasound practice. Our team has designed this course so that you can practice at a high level with your ultrasound device, and you'll be able to avoid complications, obviously, treat complications, better understand anatomy, which will make you a more precise and better injector, become the go-to person for tricky cases and complications, which, by the way, guys, is extremely lucrative. People come from all over Europe to my complications practice, and it all started not just with buying an ultrasound machine, but learning to use it like a pro. But the most important benefit of the course is that you will make a name for yourself as the practitioner who takes safety seriously and can treat complications. Complication patients are magical people. They don't just tell their friends, they refer their entire friendship group, families, and network to your practice. So this is a magnificent practice builder. If you want to find out more, simply scan the QR code to buy the course. If you use the voucher code ClariusWebinar20, you'll get 20% off the online course fee, which is normally £650. This is only valid for 30 days. Like I already said, the course is brand new, and this offer is the best you're ever likely going to get. It's already selling a great deal, and as we add more content, the prices will undoubtedly increase, so do not miss out on this opportunity. Thank you. You guys are at the forefront of aesthetic medicine, interested in the most exciting development that's hit the scene in the last decade, and you're going to be making a huge difference to patient safety by using your Clarius ultrasound. So keep learning and finding interesting anatomy with your Clarius. Your patients are lucky to have you. Thank you for your attention today. It's been a real pleasure speaking to you tonight. If you'd like to stay in touch, here's my details. Whether you need training, help with complications, or just some advice, I love hearing from you. And now I think it's time to switch over for a live demo and then a Q&A.
Excellent. Yes, and we love having you join us for these webinars, Dr. MJ. Great. I'm so excited that you're offering this course and especially this most generous offer to Clarius users. I'm going to pop over to my Clarius L20 and just do a little bit of live scanning.
My favorite.
Me too. Great. So I have a model here that has some existing filler that she's had for several months now. And the first thing I want to show you is, as of January, we've added some more specialized presets for aesthetic imaging. And so you'll see on here that we've got customized for forehead, chin, jaw, cheek. I'm going to select the cheek preset here. So lots more options for you to kind of perfect your imaging parameters. And so we know that she has filler in her cheek, or a cold gel. And so I'm just going to scan around here a little bit, and we should be able to find those. Right, and right away I can see a nice pocket of filler right here. So as you described, very hypoechoic. There's one there, there's one here. And I'm just going to decrease my depth a little bit. And so we've got bone right here and skin at the top. And if we're not sure whether that's a vessel, we can turn on our color box and just look for any vascularity in those two hypoechoic structures. And so now we can say with confidence that we do know that those are not vessels and those are filler. If I just decrease my depth a little bit here, I'm going to turn off the color again.
You can even see your infraorbital frame in there. That's really
right down in this area here.
That's that dish-shaped structure, that hypoechoic structure. And sometimes you can't always see the vessels, even on Doppler mode. So where you've got to remember, where there is a foramen, there is always a vessel. So don't go sticking your needles.
Okay. Excellent. So from there, I'm just going to go up kind of into the glabellar region, and I'm going to add a little bit more gel because I struggle with this area a little bit, but I noticed that you use a lot more gel than I do.
I use all of the gel.
And I'm resting my my pinky or my finger on her forehead just for some stability so that I don't put extra pressure. And I'm going to change this to the forehead preset as well. And that gets us some nice imaging of that area. So again, we can turn on the color Doppler, and I'll steer my color box as you recommended. I'm just trying so hard not to put pressure on. Okay, so there we go. There's our supratrochlear artery.
Wonderful. You can see most of the layers there. You've got skin and subcutaneous fat. You've got that band of muscle in the middle. And underneath, you've got that fascia layer and the bone.
So this is the fascia and then the bone right here. Excellent. So I'm just going to attempt to just change my scanning plane here and just see if we can somehow image that vessel in long axis. I don't know if I'll be able to find it again, but there we go. You can see the length of it.
Perfect.
Great. And we can actually see how it's running more superficially as we go cranially.
To superficial, and you can see that sometimes going all the way through the muscle. It's so interesting.
Yes. And the other thing I want to demonstrate is this is called auto vessel depth. And this is a feature in the aesthetics presets as well. And it automatically shows you where the most superficial depth of your vessel is.
And as that paper said, 1.5 millimeters average depth throughout the forehead. And we're here at 1.7. So, you know, that lines up pretty well.
Great. Power fan. Now, if you find yourself in extended, extended use scenarios or an educational type of situation where you're scanning for a long time, you can simply pop the fan on for extra cooling of the fan. And the other nice thing is you can attach the USB cord to the top of the fan to be able to connect to an external power source. You can plug it into the wall. Or you can use an external power pack, and that gives you limitless scanning time. So we're going to show you a little video on that before I hand you back to Janess. Thanks.
Fabulous. We're so excited about that new power fan. Thank you, Dr. MJ, for sharing your best practices for dissolving misplaced fillers so quickly and accurately. And thank you, Shelley, for the fabulous live scanning. We are going to start our live Q&A session with Dr. MJ in a moment. We've got dozens of questions here that we'll be addressing. Please do use the questions box to ask your question that we'll be answering in just a moment. But before we open the floor to questions, here's a quick question for you. We'd love to help everyone continue their journey in bringing ultrasound guidance into their practice. So please do complete this poll if you'd like any additional information, and click on as many options as apply for you. Pricing and availability does vary by region, so please request a quote and pricing if you are curious about that for your region. You may opt to speak to one of our experts about the advantages of wireless ultrasound for your practice. If you'd like to discuss scanner features, please select that option. You can also book a virtual one-on-one demo with our experts to see the new Claris HD3 in action. And we can send you more video tutorials with experts like Dr. MJ and Dr. Weiner. So please go ahead and select as many options as you wish. While you complete the poll, I'll take a minute to introduce you to the Claris L20 HD3, the world's only ultra-high frequency ultrasound in a 20 megahertz wireless scanner. It's now 30% smaller, lighter, and more affordable. So you no longer need to have to purchase a bulky system that's costly and complex to learn to bring better patient outcomes and safety to your clinic. Claris Ultrasound has changed the game in facial aesthetics. Miniaturization and innovation means high-definition imaging is now easy and affordable, with an image quality that rivals traditional systems at a fraction of the cost, representing 85% savings. And with the new Claris Power Fan, you can keep your scanner cool with limitless power supply so you can scan all day. I'd like to share a piece from a position statement on dermatology ultrasound by the European Federation of Societies for Ultrasound in Medicine and Biology. The statement is, a minimum transducer frequency of 15 megahertz should be used for dermatologic ultrasound. This means Claris is actually the world's only handheld ultrasound to meet and exceed this published guideline and recommendation for facial aesthetics and dermatology. With best-in-class high-definition imaging of the skin, muscles, vessels, and facial layers, you'll gain confidence in your needle placement, easily characterize and evaluate fillers, and more accurately treat complications, improving patient safety with consistent treatment outcomes. The secret lies in the technology with each scanner, featuring 8 beamformers, 192 elements, and artificial intelligence that together deliver crystal clear image quality only found in traditional systems, while eliminating complex knobs and buttons, making ultrasound imaging fast and easy to use. Claris is also wireless, freeing up space with zero footprint, and it's fully immersible and so much faster to clean and disinfect. Only Claris delivers wireless scanners with an ecosystem that includes a free app for your iOS or Android devices with free updates. Available with our new membership, Claris Cloud allows you to easily capture and manage unlimited exams from anywhere. Your membership includes in-app Claris videos with experts like Dr. MJ and Dr. Stephen Weiner, as well as onboarding with a Claris clinician to build up your ultrasound skills and how to learn how to use your scanner. Clarius Live delivers one-click telemedicine if you'd like to share live scanning with a colleague. And also included with your membership is the Advanced Aesthetics package, which includes AI-powered features to automate workflows like the Vessel Depth AI, which Shelley demonstrated for us today. Thanks, Shelley, as well as new aesthetic presets for the lip, temple, forehead, piriform, cheek, and chin to optimize imaging automatically. We'll take 3 more seconds to close the poll. 2, 1. Thank you for participating. We will get back to you in the coming week. I'd like to now welcome back Dr. MJ and Shelley for our live Q&A session. And I do want to let you know, because this is a popular question that I've answered quite a few times already, we will make a recording of today's live session available, as well as a PDF copy of the presentation, and those will be emailed to you in the coming week. Please use the questions icon in the menu bar to ask your questions. Shelley, if you could moderate our live Q&A session, please.
Great. Yes, thank you. We have tons of questions.
There are, aren't they?
Yes. So I see that you've already marked off a few here, Dr. MJ, but I'll just read out a few of the questions.
I've been trying to type like the wind to answer some of them.
Okay, one of the questions, and we get this a lot, is standard needles are not as easily visualized on ultrasound as special needles with a reflective surface. Which are you using when injecting hyaluronidase? Okay,
I know there's a lot of questions about this. I don't use a cannula. I use a needle. I use a 27 gauge, 1 3/4 inch standard needle. Not anything highly reflective. You can see that perfectly well on the Clarius, and I would say the imaging that I get is great. The problem that you will have is lining it up. You've got to make sure that the needle is directly in line with your transducer and it doesn't deviate. That's where all of the problems come from. So you've got to really develop an eye for keeping that needle in line with the transducer, and you will get brilliant results, even with a 27 gauge needle like I use.
And I can just kind of speak a little bit more on that. If you just remember with the physics of ultrasound, if you are using a scanner and you're coming in and your needle is coming in perpendicular to the sound beam, you're going to see that better, which is going to be the case in most of your superficial imaging. So the deeper you go, the more steep angle that your needle is going in, the more difficulty you may have in seeing the needle. There's a few little tips and tricks to that. But generally with facial injections, you're going in quite parallel to the scanner head or perpendicular to the sound beam. So it really does help to see the needle a lot better. And
you've got to make sure that the needle length is long enough to get underneath that foot plate and as shallow as you can. So you shouldn't be coming in steep. You should be, like I did on the forehead, that's about perfect. You're coming in really, really shallow so that you can get to your filler deposit in a good amount of space, because then you can visualize the entirety of that needle.
Excellent. I think you've pretty much just answered this, but one of the questions was, do you ever use cannula for dissolution?
I don't. I like knowing that I'm in the filler and I've penetrated that capsule, and that capsule, sometimes little sort of capsules form around the filler, and that's why flooding is often ineffective. And I know with that needle, I can penetrate that capsule, crack it, and know that it's going to go. So it's needles for me.
Great. Okay, are you using lidocaine for your injection entries?
Yes, I sometimes do. I often dilute the hyaluronidase itself, or the hyaluronidase itself, with 4 parts saline and 1 part lidocaine, so that it's less painful for the patient, and I found that works quite well. So I use in total a 5 milliliter dilution on 1500 units of hyaluronidase. So in the UK we have the Wockhart hyaluronidase, and that's what I use.
Great. One question, does the hypervascularity eventually vanish after filler dissolution?
Yes, it does. So there's initially, because you've irritated something, it's like rubbing your skin, it'll go red. If you irritate a vessel, it'll just become a little bit more more excited for a time, and that passes. The hypervascularity that forms as a consequence of filler, that also goes quite quickly.
All right. What is your concentration of hyaluronidase or Hylenex for dosing?
So as I've just said, it's I use a 5 milliliter saline on 1500 units. Often I use 4 milliliters saline and 1 milliliter lidocaine. So that means that a 0.1 milliliter is 30 units. And that's about all I use per sort of smaller filler deposits. So those smaller ones that we were seeing in the forehead that are about a millimeter and a half, sometimes 2 millimeters, I'll use 30 to 45 units in that. So 0.1 to 0.15, sometimes 0.2 if the deposit is bigger.
Would you say all misplaced filler remnants can be dissolved? In essence, can a patient gain back absolute original features?
Are we going to put them back to time ago before they had filler? The answer is no and never. There are multiple factors that contribute to a complication, and the filler itself is just one of them. If we remove the filler might be gone, but the complication itself has effects on the tissue. So there may be an adaptive response, and some of this adaptive response is hypervascularity that you see. Some of it may be sort of edema of the tissues, and sometimes around the tear trough that doesn't completely go. We also have two other factors. One of them is time. People age. If you've had a long-standing complication, me removing that filler is not going to put you back to where you once were. So that has to be very carefully managed, and patients need to be instructed on that. And the last is perception drift. People always seem to remember themselves as better than they were. And, you know, objects in your memory are always seen with rose-tinted spectacles. So the phenomenon of perception drift is patients always perceive themselves as complete before the complication. And when you remove that hyaluronic acid and you leave them with the effects of time and potentially with the effects even minor of the complication, sometimes they become quite despondent. So that kind of management is very crucial at the start, that is done properly. But the actual hyaluronic acid filler itself, yes, that can be removed. In most cases, there are some rogue fillers out there on the market, especially in Europe, where we're a little bit less licensed, that are much more difficult to remove. And obviously permanent fillers cannot be removed with hyaluronidase.
Right. Which sterile cover do you use?
So I use just probe covers. So the process that I have is I take my Clarius, and my Clarius is cleaned with antibacterial wipes and surface wipes. I then put a layer of ultrasound gel over the probe and then put my sterile probe cover on top. You've got two options. You can use just standard probe covers, which are sterile, or you can use something like a Tegaderm dressing. And on top of that, you then place your sterile ultrasound gel, and that can be then in contact with the skin, and you can do guided procedures, be that filler or be that hyaluronidase, with a sterile probe cover and a sterile ultrasound gel on top.
Right.
They're just called probe covers.
One last question here. How many units of hyaluronidase per misplaced filler?
Depends how big the deposit is. So sometimes I use 0.1, on slightly bigger ones I use 0.2, but I wouldn't use more than about 0.2, 0.3. If the filler deposit is especially big, and you sometimes see them in the cheek, then you can use a little bit bigger, or you can target them a couple of times.
Great. Well, okay, Dr. MJ, we're at the top of the hour here. There were quite a few questions about the technical aspects of the L20 scanner and our presets. We will be getting back to you by email with answers to your questions. As Jeunesse mentioned, this will be available to you on demand in the coming days, so stay tuned. And I will just hand it back to Jeunesse just to close things out. Thank you, everyone.
Thank you so much.
Thanks, Shelley. Thanks, MJ. If we didn't get to your question, we will follow up with you in the coming week, and a friendly reminder that you will all receive a copy of the slides and webinar recording as well next week. So please do keep an eye on your inbox. And please as well, if you can complete our closing survey to provide your feedback, that will allow us to bring you more educational webinars like today's. To conclude, I'd like to thank Dr. MJ and Shelley Gunther for all of their insights, and a very big thank you to all of you for joining us. Have a wonderful day and keep scanning. Thank you.
Thanks, everyone.